guys. Welcome to pulmonology slash immunology slash not cardiology. So I'm sure everybody's really excited about that. Yes. So thanks for being here. Today we're really lucky. We have a guest lecturer with us who is like an expert in gout and rheumatoid arthritis and all these drugs that I'm not qualified to teach you anything about. So you guys are getting a little treat today. So this is Dr. Gina Schultz. She is the Associate Professor and Vice Chair of the Department of Pharmacy Practice, so very similar to Dr. Lugo position at the Philadelphia College of Science or Philadelphia College of Pharmacy, okay? Oldest college of pharmacy in the United States, is that correct?
Exactly.
Yeah. So she got her BS in pharmacy from the University of Pittsburgh and then her PharmD from Purdue University. So I'm sure she and Dr. Hagemeyer would have lots in common to talk about there. And Dr. Schultz has done some residency training and also been a director and a clinical pharmacist for some oncology positions and some clinical directors throughout her career before she started the College of Pharmacy. So with that, I won't take any more time, but I will be listening in from the back if that's okay, because I want to learn some stuff too. So thank you.
Okay. Welcome. Thank you for having me. Do we have any Steeler fans? No. Really? So what kind of fans do we have? Like, I went to the bar in Bristol on Sunday night and watched the Steeler game, and there seemed to be Steeler fans. My husband just moved here, and so I'm down here for a week, working from the apartment for a week, and I've had this opportunity, so thank you for having me. What we're going to do today is we're going to go through gout, talk a little bit about hyperuricemia, and then tomorrow we're going to do the RA lecture in 1 hour, which I typically do in 2 hours. So if you thought I'd talk fast today, wait till you see me tomorrow. Our objectives are listed on your handout, and basically what I want you to do, and when we go into exam questions, we'll have some cases at the end. I want you to be able to recognize the side effects of the drug, because as a pharmacist, that is really a key role, and be able to pick what type of therapy to use and know when the therapies are contraindicated. So first today, it's someone's birthday today, someone's 100th birthday. If anyone went onto Google today, they could see who that was. Anyone know? Jonas Salk. Today is his 100th birthday, and we thank him for immunizations. Typically, I teach the immunization courses at PCP, but when you have these patients in mind, I thought this was relevant in a way because tomorrow we'll talk more about immunizations briefly, but when you have patients who have immune disorders, make sure you look to see if they are immunized prior to starting therapy. Right? So here's what we're going to cover. A little bit about epidemiology, signs and symptoms, and acute versus chronic treatment. Your two very important documents, Part 1 and Part 2, from the American College of Rheumatology. I think you posted them for them. And those have a lot of technical material. Don't try to memorize those. I will cover the key points, and I will cover the flow sheets as we go. But it's useful when you go on rotations and get more technical questions. So gout is considered to be a disease of kings. It's considered that because back in the day, the only individuals who developed gout were those who had high purine diets, who were very rich, who could afford alcohol. And they basically became obese, and they related gout back to this high purine diet. But now we see things differently because everyone drinks alcohol, everyone eats high purine foods, and we have many obese patients as well. So what we see now for gout is this is our most common inflammatory arthritis. And there are over 62 cases per 100,000 people per year, and this has been steadily increasing. And we can also say that it is much more common in men than it is in women. So a few definitions. First of all, what is considered hyperuricemia? Hyperuricemia, according to the labs and guidelines, is slightly different. 6.8 or 7. So any patient that comes in with a lab value serum uric acid, or SUA, as you'll see it written, is considered to have hyperuricemia. However, you can have a patient that has a uric acid level of 10 or 11 and be asymptomatic. So hyperuricemia is not synonymous with gout. The other thing that you'll see developed is you can have what's called tophi. Tophi are aggregate deposits that settle in the joints and tissues, and you can see this patient here, these tophi lumps. And over time, our patients with gout will develop these tophi, and we want to try to avoid that from happening. And I don't think you have it yet. I saw one young man look at his hands. But you don't have it yet, but just keep an eye out. So, our definitions are a spectrum. There's no specific definition, but typically we have a combination of a high uric acid level, and we have recurrent attacks of this acute arthritis, very severe intense pain and redness due to the deposit of these monosodium urate crystals in the tissues and around the joints. We can also have renal manifestations. We can have urolithiasis, which is deposits of these uric acids or uric acid stones in the urinary system. And then we can also have nephrolithiasis, which are kidney stones due to gout. There's several different types of kidney stones. One of them is related to the increased uric acid production. So I know, and I'm not, you're fortunate, back at PCP, we actually do turning point questions, and they're considered part of the grade for the students. So we're going to just see, I know you have a cardiology test soon, and I know this is the first beginning of the block, but let's just see what we know. Which of the following medications can contribute to increasing uric acid levels? Just take a guess. Which one of these drugs? Yeah.
The polling is not open.
Polling is closed. You are right. Okay, we're going to reset. It says it's open, so we'll see. Try it again. Nope, it's closed. Well, I'm not sure why it's not working, because everything is here. Well, let's have a show of hands. And cyclosporin. Can cyclosporin contribute to increase? Cyclosporin, aspirin, niacin, or losartan? Aspirin actually is the only nonsteroidal not used to manage acute gouty attacks because it can actually increase urate levels. All right? So aspirin is the correct answer here. Losartan is a uricose-uric, which means it increases the excretion of urinary uric acid. And niacin and cyclosporin can also cause an increase it can actually precipitate gout due to different mechanisms. But the big one here is aspirin. So let's move to, no, it's not going to move. Okay, now let's move to risk factors. So the biggest thing one of the things you have to do to educate patients are making sure they know what risk factors can cause gout. First of all, dietary. Dietary, primarily related to alcohol, and actually there is a higher risk of people having gouty attacks due to drinking beer than to wine. So alcohol in general increases the risk of having a gout attack, but it's primarily related to beer. And as long as patients limit their wine intake to 1 or 2 glasses a day, they won't. Those studies have shown that it doesn't increase the production of gouty attacks. But beer definitely limits 1 to 2 glasses of beer a day are recommended for these patients. And you'll see gouty attacks much more common in patients who drink 6 packs of beer or have these binges. There's a list of medications in your textbook. I mentioned some of these: cyclosporin, tacrolimus, niacin can actually cause an increased risk of gout, and you should be familiar with some of those. The other big one are diuretics. So diuretics, because you're decreasing the volume, the patient is more dehydrated, as well as you're affecting the excretion of the uric acid. So you'll have an increase. So your biggest ones are the diuretics that you worry about, and they can often precipitate a gouty attack. Elderly people, conditions, hypertension. Hypertension is a risk. Obesity is a risk. The other thing that's a risk is people with decreased renal function, as well as patients with hyperlipidemia. I mentioned before elderly patients. I mentioned before male patients. Body weight, and that the more obese you are, the more at risk you are for developing gout. And chemotherapy treatments. If patients come in with, have you had oncology yet? Okay. So patients that come in with newly diagnosed leukemias or lymphomas, they have rapidly dividing cells. And uric acid is typically elevated in these patients because of the breakdown of the cells. So in chemotherapy treatment, if sometimes our patients already have an elevated uric acid, but the other situation is when we give chemotherapy, we will lyse those cells and kill the neoplastic cells, hence producing the increased removal of uric acid. So any chemotherapy patient has to be suspected of developing hyperuricemia. It may or may not be symptomatic, but the hyperuricemia in the chemo patients actually causes renal shutdown. And if you don't prevent, if you don't increase the release, and if you don't try to avoid this occurrence, you can end up in renal failure. And finally, you'll see patients that, for whatever reason, will have elevated serum uric acid levels, either due to some of the reasons of non-excretion or they overproduce uric acid. So, pathophysiology is related to the degradation of purine, and uric acid is the final product when you degrade purines, which RNA and DNA are composed of. They have no purpose, and they're a waste product. And basically what we have is we have an increased amount in the gout patient. And we have these increased amounts due to either overproduction or underproduction, under excretion. The majority of our gout patients are due to are under excretors, which means that they cannot eliminate the uric acid. So 2/3 of the uric acid is removed by the kidneys, and the other third is removed by enzymatic degradation. And as far as the causes of under excretion, primarily it's related to the increased sodium reabsorption. So hence, that is why diuretics have a factor in causing a higher incidence of gout, because of the fact that they're increasing sodium reabsorption. So we rarely look to see if a patient is an overproducer or an underexcreter. We rarely do the workup. If we wanted to do that type of workup, we have to put the patient on a purine-free diet for 3 to 5 days, which can be difficult. And then we follow this by a 24-hour urine collection. And if the patient puts out greater than 800 milligrams of uric acid, they're considered to be an overproducer, and less than 600 is an underexcreter. So we could do this, but clinically, we very, very rarely do this unless it's a difficult patient that we're not seeming to understand what's going on with him or her. So once we have our patients showing up into the clinic, we typically will see a clinical symptom as the first presentation. So most of our patients will come in, they'll have intense pain. It will typically develop in 24 hours or less, very rapid onset. It typically develops overnight, and one of the reasons is that our body temperature goes down, and this has something to do with the pain and intensity that develops. The patients may or may not have fever. They'll have redness to the site. It'll be very hot to touch, and they will have swelling. And most patients cannot tolerate even having a blanket on top of the patient's extremity, no matter where it develops. And it typically will develop in the joints. The most common one is the first metatarsal phalangeal joint, and this is called podagra, and that is the most common one that's involved. But it can happen in the hands, it can happen in the elbows, but typically you see it on the feet. So if we look at the lab tests, we'll see elevated uric acid. We'll see if we did a biopsy, we would actually see these monosodium urate crystals in the affected joints. And we'll also see an increased white blood cell count in that biopsy. And we will see an increased ESR either in the joint, or we could see it systemically as well. So if we did a blood work, we'll see it elevated uric acid. We'll probably see increased white blood cell count. We'll see increased ESR. We do a biopsy, then we could see the crystals. And then we have our clinical manifestations. So here are a number of joints that are affected, but the biggest thing that keep in mind is there are different types of arthritis. So we have a number of different types of arthritis, and we can have acute gouty arthritis, and that is primarily seen here with the swollen joint, typically one joint by itself. We can have chronic trapezius gouty arthropathy, and that is CTGA. You can see this over on the right side, and this is long-term, long-standing complications of hyperuricemia. Rheumatoid arthritis patients will develop changes in their joints, but they're much different. This is more of a bulging type at the joint due to the increased uric acid. Rheumatoid arthritis is a little bit different, as you see tomorrow. And then finally, we can have nephrolithiasis, or the kidney stones, and we can have gout nephropathy. So what happens is over time, the gout nephropathy is also called the hyperuricemia associated with chemotherapy regimens. When we give chemotherapy regimens for the first time, kill that first round of high volume tumor cells and have a large production of uric acid excreted, that is when we can have gout nephropathy and actually end up with renal failure. So they're all treated a little bit differently. I'm not going to go into this last one because when you talk about the cancers, you'll actually should be taught that. But the biggest thing with that is hydration, hydration, hydration. All right? Because we have to make sure that we get those excreted. So our goals, our treatment, are to terminate the acute attack, prevent and reverse those features commonly associated with illness, prevent those long-term complications, and prevent recurrent attacks. And the biggest thing is patient education, because the trouble, as this patient here is saying, the trouble is I drink a lot of beer to try to forget the gout. So patients are actually need to be educated properly, because the only way we're going to solve this problem is to prevent recurrent attacks. So when we talk about trying to prevent recurrent attacks, and we're not going to be able to use this, one of the things is that patient education on non-pharmacological measures. So which of the following is true regarding the management of gout and hyperuricemia? So read through those, and someone can tell me what they think is correct. So the first one, what about shellfish? Do shellfish have low purines or high purines? Okay, I'm going to work with you because I know you have your exams. Shellfish and meats have high purine content. So patients that have recurring gout attacks, they can go with chicken or be a vegetarian for a while. That will actually help their risk of developing a gout attack. Patients with asymptomatic hyperuricemia would not benefit from these interventions. That is also false, because remember, you can still, with a high purine diet, you're still going to increase your uric acid production, and you're still going to have a high amount of uric acid in the body. So if you have asymptomatic hyperuricemia, the problem that's happening is, over time, you will damage your kidneys. And that increased uric acid load will cause deleterious effects. So you want to go with a low purine diet. Joint exercise should be avoided during acute attack. This is actually the correct answer. An application of heat, actually you already have a hot joint, your joints are really painful, and you touch them, they will feel warm, and oftentimes that's a diagnostic tool. So we apply ice to the area. So one of the solutions to this is applying ice. So what we do is we minimize alcohol, as I mentioned before. Try to get exercise, because most of these patients are obese. And the other thing is we eat less salt and drink a lot more water and use ice. So all of those solutions: cut down on alcohol, get exercise, use ice to the area, decrease your salt intake, and drink much, much more water. That will help to minimize our gout attacks. So let's move to acute management. And in your handout, what I did for you is, you have, we're going to post the slides for you, but in the handout you'll see the treatment, specific goals, and then we have our non-pharmacologic treatment, and then on the bottom of page 6 you have the acute management. So we diagnose gout, and then we get to decide how we're going to manage it. And there's a couple of different options. The first thing is to see how severe the patient's pain is. If it is below a 6 on a 10-point scale, then we're going to use monotherapy, either NSAIDs, colchicine, or a systemic steroid. If we have an inadequate response to either 3 of these, then we would go to a different agent, or we could add on an agent. And then once we have a successful result, then we're going to do the proper patient education. And if it's very severe, we can use monotherapy, or we can go to a combination regimen. And our goal is to have a score of improvement of pain within 24 hours of 20%, and past 24%, we want to have at least half of our patients have a decrease in their pain by 50%. So you want a 50% decrease in your pain score within in greater than 24 hours, and the other goal is less than 20. If it doesn't match up with this, then that's deemed to be an inadequate response. And the other thing is, make sure that you know about diet and lifestyle changes, prompt self-therapy treatment, because this is something that you need to treat quickly. It's not as bad as a myocardial infarction or heart attack, but it is something that the faster you treat it, the faster it's going to resolve. So patient education is important, because once the patient develops these, they can self-manage it once it's properly diagnosed. All right? And so our first group of drugs that we go with are the non-steroidals. Non-steroidals are most effective if you use them within 24 hours. We use a higher dose than compared to a headache. And we actually have 3 of the non-steroidals approved for gout, but we can use any of the agents. So any of the agents will be effective, and we typically would start, say, with ibuprofen. 800 milligrams every 8 hours would be a good dose. And in your Dipira book, you can see the other doses listed as well. But remember that we don't use aspirin, and remember to also continue for several days, and then we taper it. And typically, we will have complete resolution of the symptoms of gout within 5 to 8 days, and we may need to continue it a little bit longer than 3 days, but most patients will be sufficient with 3 days of therapy. So a standard dose would be ibuprofen, 800 milligrams PO every 8 hours for 3 days. And if the symptoms don't improve quickly, we might continue it for 5 days. All right? And typically, most patients will have total resolution of their gout within 5 to 8 days. And we also could use Celebrex. Celebrex is, but Celebrex has not been shown to be any more effective than the other ibuprofen or naproxen. Remember, adverse effects. Your patient should take this with food. It causes gastritis. We can have GI bleeds with long-term therapy, but typically we're not going to be using it for that long, that we typically don't have a problem. But in patients with blood pressure that's very high, these drugs can increase blood pressure. They can decrease creatinine clearance, and they can cause headache and dizziness. There's a number of cautions, and that we tend to perhaps not want to use nonsteroidals. We really cannot use nonsteroidals with severe congestive heart failure because it can actually exacerbate and make the congestive heart failure worse. If someone has active bleeding or they have peptic ulcer disease that's not being treated, we would have to really use caution with the nonsteroidals. These agents can actually increase blood pressure, so that we have a problem with, we wouldn't want to use them if someone has uncontrolled hypertension. And if someone has bad renal function, we would not want to use nonsteroidals. And finally, remember that if you have somebody on warfarin and you're using a nonsteroidal agent, you can actually anticoagulate the patient, and the patient can bleed. Right? You haven't had, have you had nonsteroidals already or not? Yes, no, okay, all right. So, now, our next drug is colchicine. So, colchicine also has, on your handout, you'll see the flow for colchicine. And our thought process through this is, are you already on prophylactic colchicine or not? If you're not on it, then oral colchicine can be used for an acute attack dose. And this is one dose that I want you to know. because this is the standard dose that we use for an acute attack of gout. And that is a 1.2 milligram dose times 1, and then 1 hour later, if the pain has not improved or subsided, we will give a repeat dose. So we'll give 0.6 milligrams in 1 hour after that first dose. And then if we decide to use prophylactic therapy, we will use the 0.6 milligram dose once or twice daily. And we can start that 12 hours later and continue until the attack resolves. The next thing, though, is if we have received an acute gout regimen in the past 10 days, 10 to 14 days, then we would choose another type of therapy. So we typically have to have a 2-week period between using that high dose of colchicine for an acute attack. And if we use colchicine, we'll have an increased toxicity within that 2-week window, and we also probably won't have a good result. It won't resolve the acute gout attack as well. So colchicine can be used for, is probably the main drug that we use, besides non-steroidals, for acute attacks. It's used within 36 hours. Our FDA-approved dose is what I mentioned. Wait 3 days to repeat this, but historically, what we've done in the past is people used to, and I'm sure that you probably still see this, people used to use colchicine every hour. And we typically would keep giving colchicine until the patient had really bad diarrhea. And they were still having pain, but they had bad diarrhea. This is a new method. This is our problem is we had complications with that, and we had some untoward side effects, and some patient deaths due to these higher doses. So this is the dose that we use for colchicine. And the other big thing is it needs to be dose reduced with people that have poor renal function. So people with poor renal function require dose reductions and down to either daily or twice weekly. And elderly patients also typically have poor renal function, so we reduce their dose as well. I mentioned diarrhea with colchicine, but the other big problem with it is bone marrow suppression, neutropenia, thrombocytopenia, and lowering of the hemoglobin. And so now we no longer have the IV formulation because we had long-term complications with that IV formulation, and patients died. The other thing is we have significant drug interactions, and it can interact with P-glycoprotein or the strong CYP-A3 inhibitors. And so we never use it in a patient who has liver failure or renal failure when you have that patient on a CYP3A4 inhibitor or a P-glycoprotein. So here's our drug interactions. They're listed in the books, in your textbook, and you should be familiar with the common ones. But right now you'll see that clarithromycin is one of the things that's listed as a contraindication. There actually was death due to a patient receiving clarithromycin and colchicine. And there's a number of other interactions as well. Verapamil, cyclosporin, those drugs will interact. So, steroids is our third drug that we can use. So, non-steroidals, colchicine, and steroids. Steroids actually are, again, in the guidelines, we can use IV or PO therapy. Our PO therapy typically is prednisone, 0.5 milligrams per day, and we do this for 5 to 10 days, and then we'll taper the dose. And some of the patients are treated with a Medrol dose pack, and then follow-up treatment. It really depends. You have to try each patient and see how they respond. We can also inject it into the joint, or we can give it IM. Most people don't like to use IM. That's very painful, and only certain agents are used. But we could inject it into the joint. Depends on the size of the joint and if it's resolving. So our dosage form depends on which joints are involved. The larger joints are the ones where we would use intra-articular injections. We can have rebound attacks, and those rebound attacks could be avoided if we tapered the dose. And if rebound attacks do occur, we could consider using low-dose colchicine and giving the steroid by injection. Adverse effects, you've had steroids, I'm sure, right? Everyone, I think every pharmacist, the one they all know about is steroids. And, you know, the thing that's different in our patients, though, is for gout, we're not going to use this long term. This is a short-term therapy, so we're only going to use it for 3 to 10 days. So you're not going to see the buffalo hump, all right? And I have seen patients that develop buffalo hump with the prednisone. I've seen patients that develop long-term glaucoma with this. But you're not going to see glaucoma or other issues. Typically, your biggest problem with the steroids, they're going to have problems sleeping, and they might need something to help them sleep because it does keep you awake, and they might be eating it a little bit more. So if you're a diabetic, you're going to see an increased glucose level. And long-term use, you can see these other side effects, but again, we're not going to be using it, or should be using it this long. If we have a patient that the only thing we can use is steroids, then you have to worry about those long-term side effects of steroids. So now we have a patient here, 180-pound male with chronic kidney disease. And he presents with an acute gout attack affecting 2 interphalangeal joints. Which of the following would be our best option? So let's take a look at these. So we've covered non-steroidals, we've covered colchicine, and we also have 2 different steroids on the list. All right? So, but we want to use naproxen. Naproxen is non-steroidal. Some people say no. And why do you think? What does this patient have is the reason why you don't want to use a non-steroidal? Kidney disease. Okay, so good. So cross out A. All right? What about that colchicine dose with someone with chronic kidney disease? That dose is too high. All right, so you're right. So this dose, we could use a lower dose, but this option here, B, is incorrect because that dose is too high. Okay? The last one, the triamcinolone, you have 2 joints. Typically, we save the IM injection for 1 joint only, okay, and we usually give it near the joint area. To use triamcinolone, and we don't typically want to use IM because that dose is very, very painful, and that's a really high dose. So that would be unacceptable. And this last one would be the treatment of choice. So in this patient, prednisone 40 milligrams for 7 days would be, you have 2 joints involved, that would be a good option. We could use it for 5 to 7 days. We could start with 40, use it for 3 to 5 days, and then taper it down to 20, and then down to 10, and then stop it. But the proper dose would be 40 milligrams once daily for 7 days. So now that's acute management. So we have to go into chronic management. So what do we have for chronic management? For chronic management, we're going to look at things that lower the uric acid, and we call that urate lowering therapy, or ULT. And the problem is who are we going to use this for, and who should receive it? Not every patient requires urate lowering therapy. So if I have a patient that comes in who has one gout attack, I am not going to put them on permanent therapy. We're going to wait and watch them and then try to determine what we need to do. So the indications are listed there. Tophi by clinical exam. If you already have advanced disease and you come in and you have just one attack but your joints are already loaded with tophi, you're going to need prophylactic therapy so you don't get more of that. Because you probably had it for a while and you just haven't had acute attacks. The other thing, if you have more than 2 attacks annually, if you have CKD, stage 2 or worse, because remembering that uric acid is high levels, it's damaging the tubules. So your biggest problem is chronic kidney disease with that high constant uric acid. And the other thing is if you have past kidney stones or that are very severe, that they diagnose them to be urate related, or if you have past ureapathiasis, that could indicate using chronic therapy. And finally, what your target goal is, you're going to try to get that uric acid to less than 6, but ideally you want it to be below 5 for improved signs and symptoms. So, our first line agent is allopurinol, or febuxostat. And then our alternative first line therapy, if we have contraindications, is probenecid. All of the drugs are listed throughout in your handout, as well as the doses. We're going to go through them quickly, but my main goal is to get to the cases. All right, so I apologize in going through this quickly, but we're going to touch upon the key points. Xanthine oxidase inhibitors, allopurinol. Widely used, they decrease uric acid production. We have 2 agents here, and we can use them concurrently with nonsteroidals or with colchicine. We typically start at 100 milligrams once daily, and if we have poor renal function, we'll use lower doses. We'll titrate the dose upwards based on the patient's uric acid levels. So we'll start at 100 milligrams once daily, and then we'll monitor the patient, see if the uric acid has come down, and then adjust the dose if needed. We used to always use 300 milligrams daily in patients, and now we start at the 100 milligrams. And we try to minimize the dose of allopurinol because of toxicities. Because our toxicities is a life-threatening Stevens-Johnson's rash. And it is found to be dose-dependent. We also can have liver failure with elevated liver enzymes. We have GI intolerance and headache. So your biggest thing is to warn patients and educate them if they're coming when they get allopurinol. If they develop any signs of a rash, call you immediately, no matter how fine. So any rash that's suspected, you also have to watch because allopurinol in the sun, people can be photosensitive, but any type of rash or bad sunburn has to be looked at. So this is the allopurinol hypersensitivity syndrome. Look at the rate. 1 in 1,000 of patients who have had allopurinol, and it has a very poor mortality. And if you've ever seen Stevens-Johnson syndrome, it's really awful and has a really high mortality rate, and it's very difficult to treat. The biggest thing is there's pharmacogenetic testing that can tell who is more commonly going to present with that, and those patients have that HLA-B 5801 present. So if we have someone of Korean descent, or Chinese or Thai descent, we typically will check to see if that's present. We also have febuxostat that doesn't require a dosage adjustment, but it's a little bit more expensive. It was just approved in 2009, whereas allopurinol has been around forever. Again, with this drug, we have neuromuscular toxicities, diarrhea, and rash. And contraindications, it can have interact, and levels can be higher if you give it with azathioprine, mercaptopurine, or theophylline. I'm going to, so this question is, which of the following is true regarding febuxostat? And I'm going to give you the answer. This is actually can be a first-line treatment, so A is incorrect. Dosage reduction is not required for CKD, so B is false. C is the correct answer. So C, in clinical trials, patients achieved a uric acid level less than 6 compared to allopurinol. So it's a more effective agent, but it's more costly, and the insurance may or may not cover that. So we have to check with the insurance first. But it would be an option in a patient who had a contraindication to allopurinol. So we can also have drugs that increase the renal excretion of uric acid by decreasing renal tubular reabsorption. And so we prevent uric acid stone formation. So what we have here is probenecid. And this is an alternative to xanthine oxidase inhibitors. So if the first two agents could not be used, or if we have problems with them, if the patient didn't respond, we could use probenecid. And the main thing is it is dosed BID, and then you can increase it to 500 BID. And another drug that used to be used was sulfampirazone, but now it's not available in the U.S. Our adverse effects are GI irritation, rash, and hypersensitivity, and we can also form stones. And you can see your contraindications, primarily patients with poor renal function, as well as overproducers of uric acid. You also have to worry about drug-drug interactions, because probenecid can increase the plasma concentration of penicillin. We actually use that to our advantage sometimes, and there's some products that sometimes will give probenecid with patients that get penicillin. But you'll see interactions with sulfonamides and cephalosporin. We also have fenfibrate and losartan. So these drugs actually, remember, are used are lipid-lowering agents, but they actually will decrease uric acid levels as well. Pegloticase is a new drug. This is a recombinant form of uric oxidase enzyme, and it is approved by the FDA for chronic gout refractory to conventional therapy. So this is a third-line agent. It's given IV every 2 weeks. We have to pre-medicate the patient because it's a pegylated recombinant form, so you're going to have allergic reactions. So the patients receive Benadryl and a steroid prior to giving it. And we only use it if nothing else works. So it's a last-ditch effort. And there's our adverse effects, and it actually can cause a gout flare-up. And if you have G6PD deficiency, you're going to avoid using it. So our last question is, a patient has a past medical history of hypertension. He has type 2 diabetes and mild CKD. He consumes 10 to 12 beers per week, and on his annual physical, he was found to have a uric acid of 7.6. What is the most appropriate recommendation. So, one of the last points I'm going to leave you with is that we have a concern in our patient because our patient has hypertension, diabetes, and mild kidney disease. Patients that have hypertension are more prone to developing chronic kidney disease. Patients that have a high uric acid will also, and have hypertension, actually have a faster onset of developing chronic kidney disease. So this patient really should be started with a prophylactic agent because we want to lower that uric acid because we're putting him at risk for further chronic kidney disease and putting him at risk for dialysis. If the patient only had hypertension and diabetes, we might go to just diet and see how we could do. But you already have mild chronic kidney disease, so at this time we would start allopurinol. That's our prophylactic drug that we would want to go with, and we would use allopurinol in this patient and measure his uric acid levels. Because the biggest goal is to try to avoid further damage to the kidneys. All right? If the patient was totally normal and had this high uric acid, we would educate them on non-pharmacologic methods, and we would also follow them closely and educate them on flare-ups to see what happens. All right? So we have these cases. Okay, a few more slides. Can we ever stop therapy? So that's the big thing in patients. Sometimes patients get tired of taking their meds. They didn't have much of a flare-up to begin with. They're poorly compliant. If you talk to patients, probably half of them stop their therapy because they never had symptoms. And so it's really patient-specific. There's not strong data either way. But if you did, if the patient is a good, well-versed patient, that would be a patient that you could consider stopping therapy. So the biggest thing is acute treatment, those three agents, non-steroidals, colchicine, or steroids. Chronic treatment, you might need to overlap. We typically use allopurinol or febuxostat, but we have those other agents available. There's a number of cases, but I think, do you end at 10 to 5? Yeah. There's a number of cases that we have that were posted on the front of your handout. So what I'm going to do is I'll let you guys talk those through, and then I'll post the answers for you, kind of like an applied therapeutics approach, and ask you different questions so you can quiz yourself after you do cardiology. Right? Okay. Does anyone have any questions? So we'll be back tomorrow, rheumatoid arthritis. Get ready to hear me talk really fast. All right, thank you.